Hello, I'm Lauren Henke, and we are back with another NRG Oncology podcast. I'm joined by my co-host, Stephen Chun, for another episode, and today we're focusing on gynecologic cancers. Today we're happy to have Dr. Robert Mannel, who is one of 3 NRG Oncology Group Chairs and Senior Vice President of the Gynecologic Oncology Group, or GOG, Foundation. In addition to his leadership with NRG Oncology, he is also the director of the Stevenson Cancer Center at the University of Oklahoma Health Sciences Center.
Dr. Mannel, welcome. You have truly had a distinguished career in clinical and translational gynecologic oncology. First off, if you could just tell us a little bit about your career path with the GOG and NRG Oncology Group.
Thanks, Steve, for having me on. Yeah, it's was very interesting. I'm going to date myself. When I was in my obstetrics and gynecology residency in the 1980s, I wasn't exposed to any type of research, but I was exposed to GYN oncology. I fell in love with it as a clinical pathway. I was fortunate enough to be accepted to a fellowship at the University of California, Irvine. And it was there that I was exposed to the importance of cooperative group clinical trials under the mentorship of Dr. Phil Desai, who eventually himself became one of the group chairs for GOG. I really got exposure to what it meant to be part of a large national organization dedicated to moving the needle and setting the standard of care. With that passion for clinical trials, I was seeking an opportunity in my first faculty position. I ended up at the University of Oklahoma, and the state of Oklahoma at that time had never had any open GYN oncology trials. So there was a huge need. So over the next few years, I recruited some great partners, and we established a culture that the best care for our cancer patients was enrollment on clinical trials. And we worked hard to make this the default mode within our section. We did that through getting resources and support. And with that, we were able to dramatically increase accrual and became a national leader in trial accrual for gynecologic malignancies by the mid-1990s. Had some great opportunities then to get into leadership positions within the old Gynecologic Oncology Group and ultimately within the NRG. Those have included the chair of the Ovarian Committee and the Protocol Development Committee for the GOG, and then ultimately a group chair within the NRG. So it's been quite a journey. It really was fueled during my fellowship, and it's a passion which has only gotten stronger as the years have gone by.
That's such an amazing career trajectory and path, and the inspiration behind it. Gynecologic oncology is so much different than most specialties in medicine. For example, I'm a radiation oncologist, and I never do the initial biopsy, surgery, and or chemotherapy for the patients all together. It's mind-boggling that GYN oncologists manage everything from initial diagnosis to surgery and chemotherapy. How has the field of gynecologic oncology evolved over the years? And what role have cooperative group trials played in that evolution?
Well, Lauren, that is a great question. GYN oncology is really unique in the oncology field in the United States. And by that uniqueness goes all the way back to its origins as a subspecialty in the late 1960s, where the founders of the GYN oncology subspecialty broke ranks with the other oncology community in the way that they were organizing patient care. So you as a radiation oncologist know most oncology care was organized around some sort of specialized skill set or knowledge set, such as radiation oncology or medical oncology or surgical oncology, and that these skills could be used against a variety of cancers. GYN oncology was organized quite differently. It was a holistic approach to cancer. And so the founders of GYN oncology wanted to have physicians who were knowledgeable all the way from prevention through therapy right into survivorship, and to be trained with skills in each of those areas. So the GYN oncologist is there to function as the primary physician, either performing or coordinating all the activities surrounding cancer care. Now, the GOG was founded in the early 1970s, 1972 to be exact, and we just had our 50th anniversary. The group was really instrumental and vital in establishing the credibility of the fledgling GYN oncology field. And over the past 50 years, the GOG and now the NRG have been vital in establishing the standard of care for uterine, ovarian, cervical, and vulvar malignancies. So I do think that the cooperative group structure, GOG into NRG, really gave GYN oncology that seal of approval and respect within the oncology community, not only nationally, but internationally as well.
So, one thing I'd like to ask about, which I know is very close to your heart, is your involvement with ovarian cancer. I'd like to share that when I was a kid, I flirted with the idea of being of a violinist, actually, a classical violinist. But one of the reasons I decided to pursue medicine was actually because my violin teacher died of ovarian cancer in 1998. And now, more than 25 years later, ovarian cancer very much remains one of our biggest challenges in medicine. Why is this kind of cancer so challenging? And what are we doing at NRG Oncology to move the needle forward for ovarian cancer?
Certainly, ovarian cancer has impacted the lives of countless thousands, if not millions, of people over the past few decades. Over 80% of ovarian cancers are diagnosed at an advanced stage. That's where the problem lies. Cure rates for stage 1 ovarian cancer are actually quite good, greater than 90% 5-year survival. But the challenge is in the advanced stage setting where prognosis is much worse. So why are we finding people at such advanced stages? Well, number one, in spite of a lot of efforts, to date, there's not been established any effective screening methods. And then number two, there's a delay in diagnosis in that there's just no clear pathognomonic sign or symptom that leads a woman to seek care. We capture 80+% of endometrial cancers as stage 1. The reason for that is a woman has irregular bleeding and they immediately know something's not right. They get on the phone and they get an appointment with a physician. In ovarian cancer, the signs and symptoms are quite a bit more subtle, a lot to do with some GI upset or bloating feelings, which are unfortunately frequently ascribed to just getting older. The other thing is ovarian cancer probably most of the time actually starts in the fallopian tube. And it starts as an intraepithelial process that then in a very early stage is able to break off and spread intraperitoneally. So this type of finding ovarian cancers at an advanced stage has always been and continues to be a major problem. And then finally, an interesting thing about ovarian cancer, of all the solid tumors we deal with, colon cancer, breast cancer, lung cancer, ovarian cancer is actually one of the, if not the most chemo responsive. We have an over 80% response rate with initial chemotherapy. The problem is almost uniformly, there's a development of chemo resistance and the patients recur. So we've improved overall survival through our cooperative group trials to the point where 50% of women with ovarian cancer now will live 5 years. But even those that are alive at 5 years, still several will succumb to their disease between 5 and 10 years, as ultimately chemo resistance takes its toll. Now, I've been very fortunate to be involved with the GOG and now the NRG, who have really set the standards for defining standard of care in the treatment of both primary and recurrent ovarian cancer. We still have a long ways to go, though, Steve, and certainly is something that the NRG is very engaged in right now.
Besides ovarian cancer, could you also give us an overview of other major gynecologic cancers that we see at NRG Oncology? And what is our general multidisciplinary strategy for those cancers within NRG Oncology?
With the merger of GOG, NSABP, and RTOG, the GYN oncology portfolio in the new NRG represented about a third, and it continues to this day. So for NRG as a whole, about a third of the trials and patient accruals are in gynecologic malignancies. Though we talk about our Gynecologic Cancer Committee, there's actually several recognized subcommittees under that. That includes the Ovarian Committee, the Uterine Corpus Committee, the Cervix Vulva Committee, the Rare Tumor Committee, and our Phase 1 Committee. So these committees are all very, very multidisciplinary. They all have a wide representation of medical oncologists, radiation oncologists, GYN oncologists, pathologists, patient advocates, translational scientists. And it's through these committees that we come up with all the way from phase 1 to standard of care defining phase 3 trials. So it's been really exciting being part of the NRG as we're able to even get a more diverse group of investigators interested in GYN cancers. And there's a lot of crosstalk. Head and neck has a large HPV problem. So does GYN malignancies. There are a lot of tumors in other sites that have P53 mutations, which is a huge problem in advanced uterine and ovarian cancer. And then the techniques for radiation oncology that are used in other sites, such as hypofractionation, can be applied to GYN malignancy. So it's been a really rich environment for crosstalk and coming up with new ideas.
So I know that all of us treating cancer really aspire to have cancer cured in our lifetime, but realistically, it's a slow path to progress. I actually speak with my 97-year-old grandfather, who was the first Asian medical oncologist in the United States, and he tells me that he thinks probably the biggest accomplishment he saw in his career was the advent of platinum chemotherapies, and then overall, he actually thinks it was Lasix because it was the first time he could control someone's blood pressure. But in your career, what have been the biggest accomplishments you feel that there have been in gynecologic malignancies, and perhaps also your biggest disappointments during your career?
I'd love to meet your father. It's been a long career for me. Interestingly, I was involved in some of the initial trials for cisplatin in GYN malignancies during my fellowship. And it's one of the reasons that I got engaged. And shortly after I came to Oklahoma, the very first patient we put on a clinical trial here in Oklahoma was a Native American, who we have a lot of Native Americans in Oklahoma, and there's a lot of cancer health disparities. And she was placed on an ovarian cancer trial with a brand new drug called paclitaxel. And so it actually ended up leading to FDA approval for the use of Taxol in ovarian cancer, and that was in the early to mid 1990s. So it started there. It's been a great career. A lot of things, as you said, have moved the needle. But to be honest with you, nothing's moved the needle more than the new immune checkpoint inhibitors. And the trial that we were able to just recently report on NRG 018, which was the role of immune checkpoint inhibitors in endometrial cancer, completely changed the standard of care in that disease and improved survivals dramatically. I've not seen survival curves move that much in a disease site ever in my career. And so it's just a real highlight to be part of an organization that is literally going to end up saving thousands upon thousands of lives because of bringing immune checkpoint inhibitors into uterine cancer. Disappointment? I wouldn't say there's very many. You know, we all have negative trials, but negative trials also confirm or affirm that the existing standard of care is still the best. And so I don't get too disappointed with that. Probably the thing that has been most frustrating to me is we always have more patients who desire participation in clinical trials than we have funding from the NCI to open clinical trials. And I think that that's something that all the group chairs share, and probably anybody that's involved in NRG. How do we get access to more clinical trials for our patients? Because it's not a lack of interest in the patients being involved in these trials, it's a lack of trials being open.
I like that you mentioned immune checkpoint therapy, which is really truly such a big innovation in the past 10 years. For those of us in the audience unfamiliar with checkpoint immune therapy, could you mention exactly what this is and how it's changed some of the landscape of NRG oncology trials?
Sure. I think most of us recognize that the immune system can recognize and destroy cancer cells and tumors. We also recognize that malignant tumors have evolved mechanisms to escape the immune system. And it's clear that the tumor microenvironment is immunosuppressive in some way, and the tumor then exploits these inhibitory checkpoint pathways to turn down the immune system. So recently, it's been discovered that PD-1 programmed death is really critical to this. This receptor that sits on the immune cells, the T cells, it can deliver inhibitory signals, these signals that function as a brake for the immune responses. Now, this is important because if we didn't in our own normal body have ways to limit the initiation and duration of immune responses, the immune system can start running amok. And that does happen sometimes, right? And you can get immune-mediated damage, autoimmune diseases, etc. So there's a need for a break or a slowing down of the immune system. The problem is this same break, which is critical for us to live with our own immune system, this break also inhibits the immune system's response to tumors. And tumors are very good within their microenvironment of basically stimulating the PD-1 systems and putting a brake on activating T cells. So when we start looking at PD-1 antibodies or PD-L1 antibodies, we're basically blocking that ability of the tumor to put the brakes on, the white blood cells. Now, I'm fortunate as an oncologist in that two of the malignancies I deal with a lot are very much involved in this pathway. One is cervical cancer, and the other is uterine cancer, more specifically endometrial cancer. So there have been, through the NRG, several innovative trials looking at immune checkpoint inhibitors in these two malignancies. And like I said, recently, NRG 018 is going to just completely change. It has changed the standard of care for all women with endometrial cancer, whether they're MMR proficient or deficient. And we know in cervical cancer that these drugs are now approved in the upfront setting. The NRG is looking at opening a trial, combining it with radiation and chemotherapy. So not for advanced metastatic disease, but rather for local regional disease. So this will be an exciting place where NRG, with our expertise in radiation oncology and GYN oncology and medical oncology, can come together in these local regional diseases and really make an impact and a difference.
With the NCI grant submission coming up, could you tell us a little bit about the short-term and long-term gynecologic oncology goals we are shooting for at NRG Oncology?
Well, as one of the people that's going to be tasked with helping to write that grant, it all starts with specific aims. It starts with your special populations that you're addressing in your grant. And so for the NRG audience out there, when we look at our abstract for our grant, it basically talks about NRG as being oncology trials really focused around two unique populations. The first is patients with gender-associated malignancies of the genital tract or breast. And second, patients with localized or locally advanced malignancies. These two areas kind of separate us out from the other large adult cooperative groups, and they're kind of our areas where we have clear leadership in. Now, our specific aims then talk about using biomarkers for risk stratification to optimize treatment. Great example for us is now in GYN oncology, we're looking at MMR proficient versus deficient and looking at different strategies for immune checkpoint inhibitors, either alone or in combination with other agents. A second specific aim is to deploy emerging knowledge in novel therapeutics for early and late phase clinical trials. And we're really have a long history of that in the GYN oncology world because we had a developmental therapeutics phase 1 subcommittee within GYN. And we do a lot of trials where we do phase 1 lead-ins. And so this has been very, very effective within the NRG for us to move drugs from a phase 1 right into a phase 2 or phase 3 setting. And then finally, looking at novel technology in radiation oncology or surgery or imaging and how that impacts treatment. And we do that all the time in our partnership between the GYN oncologists and the radiation oncologists, as I was mentioning with some of our cervical cancer trials. As a matter of fact, I was looking recently, and we've had, over the past reporting period, the past 5 years, we've had 8 trials reported from the GYN group that were practice changing or affirming during that time frame. And that included 1 in vulva, 2 in cervix, 3 in endometrial, and 2 in ovary. And so the GYN group really plays into our special populations as well as our specific aims. And so if you look at what our goals are for the future, is to continue to address those specific areas.
So, Dr. Mannel, aside from the holistic approach that gynecologic oncologists have with patients, another aspect of gynecologic oncology I have enormous respect for are the massive health disparities you face daily. I mean, we all deal with disparities in medicine to some degree, I think, but gynecologic oncologists truly deal with massive health disparities. I think of cervical cancer, where it's very well known that it disproportionately affects women of socioeconomically disadvantaged backgrounds. What kinds of things can we do at NRG and in general to improve access to care and clinical trials for these disadvantaged patients?
Steve, I think you're right on with challenges we face in the oncology world, and there are populations which the challenges are quite a bit higher. I think at a national level, it's important for leadership within CTEP and the NCI to work with the cooperative groups to really look hard at things such as eligibility criteria, the amount of data collection that's needed. Are we able to use telehealth? Can we do more local site therapy rather than expecting people to drive to major cancer centers? All of these things are doable and can be done. And I also sit on CTAC, which is a committee of the National Cancer Institute looking at clinical and translational advisory committee for the NCI. And one of the things that we have made a major initiative and is now being put into the cooperative groups is some of the things I just talked about. Really streamlining eligibility criteria, really limiting the need for excessive data collection, and focusing on collecting data, only data points which are going to be reported. These types of things, I think, will help us. We learned some things during COVID, such as, once again, it's okay to give standard of care therapy more local for the patient and still enroll the patient on a trial. And we're working with the NCI to continue some of those, quote, emergency things that were done during COVID, continue those long term, because those things address some of these social determinants of health. We need to address social determinants of health, such as financial issues, travel, etc. And there is an initiative now with the NCI and the cooperative groups leadership structure to start actually collecting social determinants of health information on all patients that are enrolled in clinical trials. This will be the first step in ensuring we have a better understanding of the challenges our patients face. I'll give you an idea. I never really appreciated this at my own cancer center. One of my junior faculty, who's an African-American woman, fantastic GYN oncologist, said, we have some real social determinants issues in our clinics, and I'd like to do a research study. I said, sure. And she picked cervical cancer. And she was asking about food security. And what we found out was over 20% of the patients in our clinic were food insecure. If you don't know where your next meal is coming from, or if you can feed your children that day, do you really think you're going to make the radiation therapy appointment? It just ain't happening. So it was an eye-opener. So what we did is we opened a food bank up in our cancer center. And we asked all of our patients a sequence of questions looking at social determinants of health. But more than that, we've put together resources to try to address them. Financial navigators, social workers, psycho-oncologists, travel support, lodging support, etc. So I do think there's a combination of things that need to occur. One at a national level to address some of the issues I spoke about previously on trial design, etc. But then other on a local level, as oncologists, we just have to have the humility to realize that our cancer patients, it's more than just the cancer we need to address. We need to be very holistic. We need to understand where they are, and then we need to have things in place that can help them.
I couldn't agree more with really all of that. Moving to a slightly different topic, I noticed that you've been recognized for your teaching and mentorship. Who who are your role models and what sort of advice can you give to new and junior investigators within NRG Oncology?
I think most of us that have gone in academic medicine, particularly within the cooperative group structure, realize the incredible mentorship and giving attitude of the people and leaders within cooperative groups. And certainly for me, there's just, I could go on and on. Phil Desaya, Tate Thigpen, Larry Copeland, and others who really embraced the role of being a mentor in helping us at the University of Oklahoma become successful as a group, and then myself as an individual. What I learned from all of that, it really does, it takes a village. That's just the bottom line. So for young people, new investigators, I should say, I think that the NRG is very committed to mentoring and career development. We have a committee, the Early Career and New Investigator Committee, and it has mentored fellowship programs within it. The chair of that committee is Dr. Gandhi, and co-chairs of Angela Secord and Rastogi. They are really passionate. And I will tell you that because they come to us and they have ideas and they have really phenomenal connections. So it's not just all within the NRG, but how do we leverage other entities that work with the NRG for people to be successful? I can give you an example. In GYN Oncology, the GOG Foundation has invested millions of dollars in young investigators. They have new investigator awards as well as GOG scholars. These awards provide support for travel to the meeting, provide support for, if you're a scholar, actually provide salary support for you and your mentor, and also money for helping develop an investigator-initiated trial. People in these programs are also partnered with mentors on various disease site committees, and it's a great opportunity there. So for young investigators, what I would say, or new investigators, get involved. Bottom line is show that you're interested. Join the Early Career New Investigator Committee, volunteer to do things, apply for some of the scholars or new investigator mentoring programs, be sure you participate in meetings. Number two, accrue patients. We're a cooperative group. You get known because you and your site are accruing patients and you're showing a commitment. Build upon those things. Then with starting to put in ideas and protocols, work with the disease site chairs, put in some ideas, and then you will start seeing yourself mentored forward. Being a cooperative group trialist, a clinical trialist as a career pathway is phenomenal. It's filled with lots of rewarding moments, but it's not a short-term game. It's not a sprint. It's not, I'm going to get it done this year. It's literally a career pathway over several decades. It's incredibly rewarding. There is a process to it. You can't take shortcuts, but I have found that throughout my career, whether it's in GOG, NRG, or CTEP as a whole, that there are incredible mentors and leaders who are looking for early investigators who want to be the next generation.
Well, Dr. Mannel, I'd like to thank you again for taking the time to speak with us, and I also want to wish you the best of luck on your gynecologic trials. The NRG Oncology Group is supported by grant funding from the National Cancer Institute of the National Institutes of Health, and content of this podcast does not necessarily represent the official views of the National Institutes of Health. Thanks, everyone, for tuning in, and happy trials.